Hello and welcome to this second video. Hopefully you've already watched the first one, which was about airway and breathing. And now in this video, I'm going to talk about circulation and defibrillation and what's kind of going on with the heart and things like that. So I'm just going to start off with some drawing. And as you will remember, I'm not the best drawer in the world, but I like to have a go. So the first thing is I'm going to draw the heart. So the heart has got two sides to it. So we're going to start off by looking at the right side of the heart. And I'm just going to draw it like so. And in the right side of the heart, we've got the atria. And I'm just going to draw a valve coming up here. So I know it's a little bit strange at the moment, but we've got blood vessels feeding into the atria, and that would come up the back and come into there as well. So this here is the right side of the heart. Drawing it on blue because it's rich in carbon dioxide. There is some thickness to these walls up here. Okay, so this is our muscle mass. So this would be the inferior vena cava, superior vena cava. They both will feed the heart muscle, if you like, or go into this reservoir. There's a valve here which goes to the left ventricle. Sorry, we're talking right. So this goes to the right ventricle. And if you remember from my other video, from the right ventricle, this would actually pump off to the lungs. So I'll add them in a moment. And if you remember, all blood vessels that go away from the heart are arteries, and all blood vessels that come towards the heart are veins. So because they're going away from the heart, they would be arteries. Because they're going to the lungs, they'd be the pulmonary arteries. So let's draw the other side of the heart in now. So just going to do this. Oh, it's kind of heart-shaped, but laying obliquely, and that's very purposeful. So again, we've got the aorta, the atria at the top, and we've got muscle mass, which is thicker than that of the right side of the heart. So this is muscle mass down here. And then we've got our ejection, which would come out of here, and this would be the arch of the aorta. So if we look at the direction, we've got the lungs. Let me quickly just draw a pair of lungs. This is sat in the middle of the lungs. Do you remember we had the diaphragm, we had the right lung, we had the left lung, 2 lobes, 3 lobes, and we had the heart. The heart there sat in the middle of the lungs. And if you remember from the previous video, we've got the trachea branches off the bronchus, the bronchi, etc., etc. You need to watch the other video to make that make sense. So these blood vessels which go off, are going to the lungs. Okay, this here is going to the body. So the return from the lungs will feed into the atria at the top here. So this is from the lungs going in that direction. So these are going towards the heart, so they're veins. So these are pulmonary veins. Okay, so I'm hoping that kind of makes sense of it. So we need to think about how the heart muscle kind of works. So this is the same thing that I've drawn here. So this is the arch of the aorta going out. This is then the superior vena cava. This would be the inferior vena cava. This would be the right atria going through the valve to the right ventricle. From the right ventricle, it gets pumped up here through the pulmonary arteries off to the lungs. So that goes off to the lungs, gets rid of the carbon dioxide, takes on the oxygen, so it returns via the pulmonary veins to the left atria, through to the left ventricle, out the left ventricle, through the arch of the aorta. And that's the basic circulation. So I hope that's what it kind of sees there. That's the way it pumps. Now, the heart has got two jobs. Not two jobs, sorry. The heart has got two mechanisms to it. So the pumping action, pump, 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 is what is happening. And that is controlled by the muscle mass going around. And then because of the contraction, it squeezes, it pumps blood out. Now, when it pumps, we get a double action. So the two atrias, the two top chambers, contract at the same time. And because they contract at the same time, they both send blood through to the ventricles at the same time. Then both ventricles squeeze at the same time, and they eject blood out either to the lungs or around the body at the same time. So that process happens. So we get a top and a bottom pump. So that's where we get the kind of the double action. So we get a ba-boom, 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 or lub-dub, lub-dub. Some people say it in different ways. As you progress through your years, you'll do heart sounds, etc. But the basic concept is we get a double beat. When we feel a pulse, we are only feeling the arterial blood flow. So we only feel one beat. So we don't feel the top beat of the atrias. We only feel the beat of the ventricles, and we only feel the beat from the left ventricle. So when we feel a pulse, we're feeling the left ventricle. So how many times does that beat? So when we're feeling for a pulse, we are looking at 60. Let me cross that out for a second. Sorry. Ooh. So we're going to be looking at a pulse rate, a PR, yeah, of 60 to 100 beats per minute. Remember when we looked at the previous video, we looked at the respiratory rate. So RR respiratory rate was 12 to 20 breaths per minute. This is now 60 to 100 beats per minute. This is one which is different that we quote here in the out of hospital and compared to the news score, which you may see in hospital. So a 0 on the news score is 51 to 90 off the top of my head. So if you're less than 51, you start adding to your score, which is a bad thing. And if you're above 90, you start adding to your score, which is a bad thing. But in outer hospital, the JR calc, we use 60 to 100 as being our standard norm, okay, for the average adult heartbeat. We'll talk about children and pediatrics on another session, but that's what we're looking for. So respiratory rate 12 to 20, oxygen levels 94 to 98, pulse rate 60 to 100. Now, you may have heard about something called a heart rate. Well, this is actually slightly different. So a pulse rate is what you actually feel. And I would like you all to be very good at doing a radial pulse check. So when we do a radial pulse, and if I'm doing it on myself now, I'm right-handed or dominantly right-handed. So I'm going to use my two fingers of my right hand to feel for a pulse. Now, I know it's right in this groove here, but how do I find that? Well, I can hold my hand up with my thumb. If I now get 3 fingers and I come off my thumb with that third finger, keep my fingertips on the very top, roll my hand down, the pads of my fingers are now directly over my radial pulse. They're spot on, and that's a really good way to help you find it, and you can do this on patients and other people. So just again, 3 fingers. Once that third finger is off of the thumb, so there, fingertips directly up, roll them down, the pads of my fingers are directly over the pulse. I can feel my ligaments down here, and it's always above that. I can feel my radial bone above, and it's in that little groove there, little notch. So, you know, I can feel around different ways, but that's where it's going to be. So I can then count that. So I need a timer, and I can count it. Now this 60 is very close to a timer if I'm looking at hands, because that's 60 beats a minute as well. Don't get into 60 beats. For me, when I'm counting a respiratory rate, I will always do it over 30 seconds and then double it. If I'm unsure about the respiratory rate, I'll do it for a whole minute and make sure I get it accurate. When I'm doing a pulse, I'll very often do it for 15 seconds and then times it by 4. But if I'm unsure about that pulse because it was irregular or something else, I will then do it for a whole minute. There are some things that will change the strength of the pulse. So the first thing is, if I flex my wrist back, that should push the artery closer to the surface, so it should make it easier to find. If I tuck my hand in, it actually hides that artery, so it makes the pulse harder to find. So I always start off in that neutral position. But if you're struggling to find a patient's pulse, just move the hand very gently back and forth to see if you can find it. The other thing is you should always do it where it's level with the heart or thereabouts. Because if my hand is down low, I know you can't see it now, my heart will compensate for that. So it will reduce how much it uses the artery because gravity is taking over. So my heart rate actually gets fainter when it's down low. Okay, so not what you may think. All right. If I raise it up high and I take my pulse, it actually gets stronger because my heart compensates for gravity and because it's up high. So the heart has to pump harder to get it up there. So it actually becomes stronger when it's up. Now, it's really interesting because if you play with your own pulse and you get it there and you experiment with these different things, it takes a few seconds for it to kick in. And for different people, it can take longer or slower, depending on the quality of your arteries and your fitness and other bits and pieces. But some people think when they put their hand up, blood drains away and it goes quite pale. When you put your hand down, blood goes to it, so it goes red and your hands change color. And they think that's to do with your pulse as well. Well, it's not. That's your peripheral circulation, so your capillaries, compared to your arterial circulation. And when we come to talk about trauma and catastrophic hemorrhage and stuff, raising the arm up for catastrophic hemorrhage isn't any good because the heart compensates and pumps harder. So, you know, we've got to understand that mechanism where a little cut on my finger, elevation and pressure does the job because it's not catastrophic. We'll cover that in another session. What I want to go on to and talk about is heart rate a little bit more. So when we talk about the heart rate, there's electrical activity across the heart because muscles work with electrical impulses. Has anyone ever used a TENS machine for pain relief or for circulation and stuff? You put 2 electrodes on you across a muscle and it gets the muscle to twitch. Well, your muscles work with electrical activity. When we talk about muscles working, muscles only do one thing. They contract. So a muscle contracts and then it naturally relaxes and then it contracts again and then it naturally relaxes and then it contracts again. And that's how the heart muscle, the myocardium, works. So where's the electrical activity? Well, first of all, we've got a couple of nodes, okay? And these nodes here, so right, a bit better there. One there and one there, okay? So these are the electrical nodes. So this first one is the SA node, yeah, sinoatrial node. We can think of that as being the sergeant of the army, the SA, sergeant of the army. So the SA node, sinoatrial node. But the sergeant of the army, this is in charge. This node has got hundreds of soldiers. That's why he's the sergeant of the army. Hundreds of soldiers all around him. So these first lot of soldiers are covering all of the atria. And the sergeant of the army says, jump. And as he says jump, like a Mexican wave, the first layer around him will jump. And then the next layer behind them, and then the next layer behind them. And that is a ripple effect, but that happens very quickly. So the SA node, the sergeant of the army, says jump. soldiers like a Mexican wave jump. So you can imagine my hand here, the sergeant is stood here at the top and says jump. This is the first line of soldiers. They jump like a Mexican wave, then the next ones, then the next ones, and so on. So as they jump, they actually contract. And as they contract, the volume inside gets smaller. So what happens is, as the sergeant of the army here says jump, and we get this Mexican wave effect around the muscle, and this is just of both atrias, as that happens, it squeezes blood from the atria into the ventricles, and that will happen at the same time. Okay, if I was to look at that on a electrical pathway, so if I was to measure that electrical activity, well, with all electrical activity, the first thing I've got to do is find whether there's a plus or a minus, and I've got to find that neutral line. Okay, so we've got plus and minus, and then we've got the neutral line. So I'm measuring this, nothing's happening, nothing's happening. Suddenly the sergeant says jump, and as he says jump, we get a nice little dome. Because the sergeant said jump, these guys have all jumped in a nice systematic way, and as they've jumped like a Mexican wave, the electrical activity has gone up and then comes back down, more or less to that neutral line. And there's not a lot of muscle mass up there. That's how it happens. This here is the second in charge. So this is the AV node. So the atrial ventricle node, the army veteran that's been there for years, I don't know, I'm just making it up now, but essentially they're second in charge. They are constantly watching the sergeant, constantly. And when they see the Mexican wave coming towards them, got to them, the second in charge turns around, and then the second in charge has got a whole army down here, down the ventricles. Now, these soldiers are big, powerful soldiers. Remember the muscle mass that we looked at? Let's just have a look at this on our heart muscle again. Let's put it. Yeah, so this is the same. Hardly any muscle mass, big muscle mass down here. Okay, so this is what we're looking at. So the SA node on the outside of the atria here, AV node at the top of the ventricles, and coming down the septum. So the septum is a wall between anything. So this is the septum of my nose. This is the septum of the myocardium, so the heart muscle. So now that the second in charge has seen it come across, he now says jump to his soldiers, and they jump with some force. They've got size 12 boots, and they really make an impact. And as they do that, they then relax. Let's bring that down to here. So the next thing we do is we see the second in charge turn around. So we get a slight negative deflection. Okay. Then we get the big, massive jump. And as we do the big, massive jump, we get a big spike. Then, as everyone relaxes, we get another dome, as all the soldiers said, that was good, wasn't it? And they relax. There is a universal way of looking at this, and this is what we call NSR. This is normal sinus rhythm. And if we were to apply the universal way of looking at it, this here is what I call a P wave, Q, R, S, T. They do not mean anything other than I could talk to a cardiologist anywhere in the world, and I'll be talking about P waves, and they would know exactly what I mean. Or I talk about the S wave or the T wave, R wave, and that is a universal language that we all use. So this is the real basics of ECGs, electrocardiogram. Okay, that's how we would measure the electrical activity that's going across the heart. So this is normal sinus rhythm. This is 1 beat. And remember, there's 60 to 100 of these per minute. And then we would come along, we would have a P wave again, maybe a little Q wave, an R, an S, and then a T. And then we would come along and we would have a P wave, a Q wave, an R wave, an S, and a T, and so on. So this is normal sinus rhythm. Okay, so that's something you need to be aware of. Now that will tweak and change depending on the angle you look at it. We often look at it from lead 2, which essentially is a pair of eyes looking from this angle down here. So we're looking up at the heart, so we can see the SA node, the ventricular node. So we look at it from down here up towards it, and this is a really strong pathway, and that is what we see. I hope I've explained that in the way that makes sense and you understand it, because really you need to understand that concept, this what we just talked about first, and then you can build on that. If you don't understand this, please go to the books, please come and see us. Make sure you understand this concept first, because once you go from here, then it gets more complicated. Okay, so back to the heart muscle itself. So here's our heart muscle, and here it is. You can see the different parts of the heart and everything else. And when we look at this, the heart muscle, I've talked about these electrodes, which are all around. These are all soldiers. Well, a soldier is only as good as it's maintained. If you feed the soldier, give it food and drink, the soldier will keep on performing. And all we want it to do is jump when we say so. If you stop feeding that soldier then becomes hungry. Not only do they become hungry, they then become lethargic. When they become lethargic, they also can become confused. When they can become confused, they become erratic, and they start doing things that are out of character and not the norm. So it's really important we feed these soldiers. Now, these soldiers are cells. And if you remember from the previous video, what we need to feed a cell is oxygen, glucose, insulin to allow the glucose to go into the cell. They produce energy, produces a waste product of carbon dioxide. So now we've got our soldier. If we go back to our picture of a cell, and this is going to be really tiny down here. So we've got our cell. Yeah. We've got our oxygen-rich blood coming in to feed it. So this is our O2. So that's going to go in. Then what comes away is the CO2. And that's going to go away and then go back. So the circulatory system carries the food and drink, the nutrients, everything that the cell needs, the soldier needs. So it's carrying that, and then it needs to take it away. So if we come back and look at the heart muscle itself, around the heart are all these red and blue blood vessels. They are nothing to do with the actual pumping chambers, other than they supply the soldiers, the cell muscles, with the food and drink, and they take it away. So in essence, the soldier can stand there, food and drink will be brought to them, they jump when they're told to jump, as per the sergeant of the army, and then their waste product gets taken away from them. This is brilliant. This all works out. Now, I don't know if you can see it, the very, very first branch off, and this comes from the arch of the aorta, yeah, the very, very first branch off of the arch of the aorta. Remember, that was being pumped from the left ventricle out around the body, because that's where we felt the pulse from, feeds the heart muscle itself. So that's the first branch off the aorta. And again, we've got different sections of that. I'm going to leave you to research names and get it correct. I'm just going to go through the basic concepts. So the first branch off feeds the heart muscle itself and goes to every single cell of the heart. If we enlarge that blood vessel. Okay, so if we think about that blood vessel here, what can happen over time is deterioration. So that blood vessel starts off nice, big and round, but we can get deterioration and some problems. Having a look at that in more detail. So what we've got here is a nice big blood vessel. That's how it should be. Okay, and what we can see on this one is just a little bit, and it hardly looks any different until we get to this one here. So if we now start looking at this, can you see the plaque building up on the inside? And as that builds up, if we look at the circumference of the blood vessel, it gets narrower. So less blood can be transported through it, and that can get narrower and narrower and even create a block. And that's a problem. So our blood vessels, here's my other bit. I don't know if you've ever seen these Chinese thumb locks. Yeah, so we've got this, yeah, and now my fingers are locked in there. The way this works is it stretches and it narrows. So as I change the shape of it, the diameter inside change. Your blood vessels are constantly working like this, constantly making this motion, doing this. And that's how we raise and we lower blood pressure. So if I didn't have blood pressure, if I now stood up, because of gravity, blood would drain down, go away from my brain, I would pass out. So as I stand up, my blood vessels contract, which maintains blood pressure, so it goes up to my heart. When I'm relaxed, my blood vessels relax, so the diameter of my blood vessels is wider, so blood starts to pull down. So again, understanding that concept is equally as important. So thinking about these blood vessels, them soldiers are that first branch off the aorta. They get all the food and drink they want. Happy days. They will stay there all day long as you feed them and you take away their waste. That is great. What happens when we get a narrowing, and this could be built up from cholesterol, plaque, this could be from bad diet, lack of exercise, hereditary issues, but essentially we're now getting a build-up. Well, when we try to get our blood vessel to move, can you imagine doing that if this was hard and solid like this? That then would cause problems, because now the soldiers don't receive as much food and drink as they want. Yeah, so we get twitches. The soldiers start to feel aggravated. They're not happy with what's happening because they're not getting the food and drink. They're starting to get tired. They're hungry. They become lethargic. They become irritable, aggressive even. And this now causes problems. So let's take this on to the next level. When I'm looking at that heartbeat and I've got that normal sinus rhythm happening, so that's happening continuously on my ECG, so I've got normal sinus rhythm, okay? Then a soldier gets hungry. Well, what we can get is a bit of a bleep. So we actually get a long pause before the next one. And then it kind of works as it should, and it works as it should, but we've got this long pause. So we've suddenly got an irregular heartbeat. So rather than it being boom, 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 60 beats a minute, we've got a boom, gap, boom, 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 gap. So we now get an irregular heartbeat. And that's something we can feel for when we're feeling people's radial pulses. So that's thing we should kind of be aware of. What I want to get on to is the last kind of bit of this. What happens if there's absolute mutiny? So a soldier down here is hungry. We may get a little bit of an irregular beat. What happens if a soldier up here is hungry? Well, if that soldier misses the beat, what does the soldier behind him do? Because the soldier behind, all they've ever done is follow the one in front, because they do a Mexican wave. That's their job. That's all they ever do. A Mexican wave, follow, follow, follow. That's now a little bit of a problem. This soldier down here is like, what's going on over there? Hang on a minute, there's problems. This one then gets confused and shouts, jump. These ones behind know no different because they just copy, so they jump. And suddenly the second in charge is like, whoa, 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 it ain't your job to jump. What's going on here? Next thing we know, we've got mutiny. We've got people saying jump. We've got people jumping, people not jumping. We are all over the place. If I put that all over the place onto my ECG and I look at it, this looks very funny. It looks very funny. This is not normal sinus rhythm. This is ventricular fibrillation. At this stage, the heart from going boom, 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 maybe it went boom, 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 but it maybe gone irregular, but now it's gone to, I'm not doing anything. The heart muscle itself is not beating because the electrical activity is not organized. Yeah, but because you've got mutiny going on, you've actually got a shaking going on. This is the ventricular fibrillation, the very funny pattern that we can see. The heart is not beating, but it is quivering. And as them soldiers get less and less food, so I'm just going to carry on that kind of VF here, and as they get less and less and less, we can see it running out. And then it goes into asystole. So where the heart was beating, the person was alive. As soon as it stops beating, at that point, they're in cardiac arrest. But it doesn't mean the heart has stopped doing everything. So the heart can be quivering, but it's not pumping blood. That quivering will get less and less and less until everything stops. Now we've got no beating and we've got no electrical activity at all. So how long do you think it is from here, the point of cardiac arrest, to here, the point of going into asystole? How long? It's roughly 10 minutes, roughly. For every 1 minute that goes on, we lose 10%. So over 10 minutes, we've lost 100% of electrical activity. So roughly 10 minutes. It all depends on the person. Some may be 8 minutes, some may be 15, but average out 10 minutes. Every 1 minute is another 10% lost. What can we do about it? Well, the first thing we can do is recognize it. If they're in cardiac arrest, the heart has stopped pumping, we will have other signs and symptoms. Do you remember that triangle to diagnose history, signs and symptoms? Well, they may have history of chest pain. They may have had history of a heart attack, myocardial infarction. That is not cardiac arrest. They may have history of exercise or exertion. Lots of different things like that may be the history. The signs, you may see they're no longer breathing, because if the heart's not working, the breathing stops. So them signs, they turn very blue because they're not getting rid of their carbon dioxide. So they look blue, which is cyanosis, known as hypoxia, low oxygen levels. So we look for that. Symptoms, we can't get any because they're unresponsive. This is an unresponsive patient. If they're in ventricular fibrillation, the heart has stopped pumping, they are unresponsive because the brain has stopped its function. So there's some of the history and signs that you might use to recognize this. We can then manually pump the heart. Yeah, manually pump it. We know the average heartbeat is normally 60 to 100 beats a minute. When we manually pump it, we pump it between 100 and 120 beats per minute. Most people do it too fast. Okay, so we're only going to do it between 100 and 120. We're now manually pumping them chambers. We are nowhere near as efficient as the heart on its own. But what we will do is hopefully maintain VF. So by us doing chest compressions, which is the start of CPR, cardiopulmonary resuscitation, we are maintaining ventricular fibrillation. And if we done really good chest compressions, we did it to a depth of 5 to 6 centimeters at a rate to 100 to 120, and everything was on our side, we would maintain that VF indefinitely, providing the soldiers with the food and drink they need, taking away the waste products they need, and keeping them at the state they're in. We don't necessarily improve them. So what do we get to improve them? Well, this is where the AED will come along, or the defibrillator. So once we get an AED, we get 2 pads. Remember, we look at the heart from here. So what we actually do is we put 1 pad here. So that pad is actually mid-axillar, halfway underneath the left armpit. That's the same view as what we're getting. So underneath the left armpit, so right away round to the side, so mid-axillar, middle of the armpit, just below the left breast. The other pad we then put up here, okay? And that's by the right collarbone. And then the defib will look at the rhythm. There is only one pattern that the defib recognizes, and that's this very funny one. Ventricular fibrillation. This pads, the AED, does not recognize asystole. It does not recognize normal sinus rhythm. So the most important thing of understanding the concept of an AED is understanding the defib, the pads, the AED will only recognize ventricular fibrillation or nothing at all. So it doesn't know all the other bits. It is the operator's responsibility to apply the defib pads. We only ever apply the defib pads to someone who we have diagnosed to being in cardiac arrest. If we recognize cardiac arrest, and that's where we follow our ABC approach, we recognize cardiac arrest because with an open airway, they're not breathing and they've got no signs of life, no circulation, but no signs of life. We deem that to be cardiac arrest. Breathing is the biggest element. We then put the defib pads on. When the defib pads go on, if they recognize this very funny pattern, ventricular fibrillation, they will advise us to shock. And when we then deliver the shock, that is literally all of these soldiers in mutiny. They're all shaking and doing different things, not feeling well. That shock is literally, oi, stop. We actually stop the heart. That is what the shock does. And when the heart stops, the SA node, so the sergeant of the army, says, thanks for that, mate, jump. And all the soldiers jump in a nice rhythmic Mexican wave style, as they are meant to do, back to normal sinus rhythm. That's how it works. On some occasions, it will happen first time. On other occasions, it won't. Can you imagine a classroom full of rowdy school kids and the teacher there has just kind of given up? The teacher's stopped, not controlling them. The kids have gone wild. Someone else comes in. If they get in there quickly and, oi, you lot, listen to the teacher, you might get their attention straight away. It might be you have to shout 2 or 3 times, but you've got to give them a gap in between. And that gap is 2 minutes. So the AED will measure every 2 minutes, am I in ventricular fibrillation or not? If it recognizes ventricular fibrillation, it advises a shock. If it doesn't recognize ventricular fibrillation. So it could be they're in asystole, it could be they're in normal sinus rhythm, or any other pattern. It doesn't advise a shock. It will only shock if it recognizes ventricular fibrillation. And then it will say jump. It will say stop. Sergeant Major then can take over and say jump, and we're back to normal sinus rhythm. If we get them back, it's what we call a ROSC. So if we get them back, we get a ROSC, ROSC, which stands for return of spontaneous circulation. So return, it means it had gone, of spontaneous, all by itself, circulation. The heart is now beating for itself. Doesn't tell us about breathing, tells us about circulation, return of spontaneous circulation. That's if we do get them back. If we don't get them back, we can do ALS, advanced life support, for 30 minutes. And if there's no success on that, we then get what we call as a roll. A roll is recognition of life extinct. You can only do that if you can do advanced life support. So with you guys at the moment doing basic life support and maybe intermediate life support, you can't do a roll. So you can't recognize life extinct. Okay. Having said that, you might recognize it's not suitable to start CPR, decapitation, incineration, hypostasis, rigor mortis. You might recognize those and say we're not starting, or there might be a DNA CPR or something like that. So you're not going to start, which is fine. And again, you're legally allowed to do that, and make sure you read around that so you know the list of when you don't start CPR. But once you've started, we will continue until we are too exhausted to continue. Someone else tells us to stop, which is likely to be an advanced life support provider, and they're going to do or done 30 minutes of advanced life support, or we get a ROSC, a return of spontaneous circulation. So if we get that, we will then start our whole process again, and we go back to airway. Is their airway open and clear? What is their SpO2? Is it 94 to 98? If not, do I need to give them supplementary oxygen? What's their respiratory rate? Is it 12 to 20? If not, do I need to ventilate them? You only ventilate if you're going to be beneficial. So we ventilate if the rests are less than 10 or greater than 30 and ineffective. So if someone's breathing at 8 rests per minute and they're maintaining oxygen, they look good color, their SpO2 is 96%, they're fully conscious, they do not need ventilating. But if someone is unconscious or unresponsive, they look hypoxic, their SpO2 is 88%, their rests are 4 per minute, we can then ventilate them, where we breathe for them, but we're not doing chest compressions. So this is where we go from the mix of basic life support to intermediate life support, and it's then skill levels that we've been taught. Please stick within your own scope of practice. Only ever use the equipment you are trained and allowed to use, and you should be able to use that efficiently. I really do hope this video has been of some advantage to you. I hope it's kind of made sense. If it hasn't, or you've got questions, please send me an email. I'll be more than happy to try and explain it. If it has been good for you, share it with others. Take care for now, and I'll see you on practical sessions.